Committee in the special session. Today is Wednesday, February 10th, and it is about 4:36 in the afternoon. Welcome. We do have I'm going to make some open remarks. I'll turn it over after that if my vice chair wanted to make any, but as you know, our current MCO tax is expiring, and in order to obtain federal approval, California must restructure or risk losing $1 billion annually, and that's quite a bit of money. As we strive to protect vital funding for our Medi-Cal program, we must ensure that our plan maximizes federal dollars and avoids a negative impact on the efforts to control healthcare costs. The restructured tax swap we are discussing today accomplishes both these goals. The bill provides a significant net benefit to the healthcare system at large, and let me restate that, a significant net benefit, including a net benefit to the plans, and it allows California to draw down over $1 billion annually for the Medi-Cal program. The Department of Healthcare Services Director Jennifer Kent is here to present the administration's MCO tax reform proposal, which is contained in SB X215. Ms. Kent is also prepared to answer any questions that members may have. Then we will hear from the supporters as well as the opponents of the bill. I know some are concerned that this proposal does not currently include funding for services for the developmentally disabled. Discussions on that very important issues are ongoing and promising, and everyone, at least I can speak on our behalf, and our caucus are committed to making sure that that happens. I want to take just a minute to personally thank Ms. Kent, the administration at large, the plans, and numerous other interest parties for all the work that has gone into this proposal. It's been a long time coming. We started on it sometime last year. From the beginning, numerous groups have worked in good faith to solve the funding problems before us, and I want to publicly state how proud I am that we have all gotten to this point and how well they have worked together, and I want to thank everybody because we have done it for the good of the state of California. I'd like to see if the vice chair would like to say any opening remarks, and if not, then we'll go ahead and get started.
Thank you, Mr. Chair, and members and everybody in the audience. I just glad to be here today and just want to express we're here to work to try to solve the many problems in our states, but there are some concerns I just would like to start off with, just trying to remind us of what happened last year. In 2015, our legislature passed a record-setting $265 billion budget. However, despite $10 billion in additional new tax money which came in, our governor and colleagues in the majority made a conscious decision not to use this revenue to appropriately fund reimbursement rates for Medi-Cal providers and for those provide those essential services and care for people with disabilities like cerebral palsy and autism and many other debilitating illnesses. But here's one concern that I had, or of many, is they did spend money and allocated $142 million for free cell phone minute plans, which included unlimited texting, as well as $23 million to expand the welfare cash card programs to provide for recently released drug felons. Additionally, since the budget was passed in June, our state has been fortunate to see almost another $6 billion in unanticipated revenues. So, in fact, it is my understanding that the budget as presented already funds Medi-Cal with the general funds, which asks the questions, why are we here today taking this action? When I consider California what a great state it is, if you've read CEO magazine, over the last 11 years, they've asked the questions to the nation's top 500 CEOs. Where would you most likely want to live? California is a state, but then where do you want to do business? We always rank last, and I believe that's 11 years in a row. And that's because we already have some of the highest state income tax, sales tax, gasoline tax, DMV fees. Even my dog license fees have seen a lot of increases for my pets. Anyway, the simple fact is California is a high-cost state, and it makes it rough on small businesses and working families. And I certainly know in my district, and as I go across the state, most of our citizens are not wanting another tax increase. And so that's why groups like the National Federation of Independent Businesses are in strong opposition to this. And I understand that we are debating the merits of this proposal today, but I am concerned that the costs on this tax will be imposed upon businesses and eventually be passed on to consumers, which again is some of the questions that I'd like answered. And we know that this proposal is very complicated. Therefore, as we continue this discussion, there are some questions that I'd like to see addressed today. The first, is this simply yes or no? Is this a tax? Which will be asked again later. Second of all, does this proposal, in fact, give the Department of Health Services the ability to increase taxes without the legislature's approval down the line? And then lastly, is there any kind of an analysis available with empirical data that proves that this tax will not raise costs on businesses or families with less than 100 employees, and will it guarantee that no additional costs will be passed on to our consumers or businesses? And so in conclusion, we remain, us Republicans, committed to working with our friends across the aisle to further the shared goals of government accountability, prudence, efficiency, and effectiveness. All things all of us have pledged to do to protect the good citizens of the state of California. And so let's keep this in mind as we continue this discussion today, and thank you for allowing me a few minutes.
Thank you, Mr. Vice Chair, and we'll now move on to item number 2, overview of the administration's proposal. I'd like to call up Director Kent, Department of Healthcare Services. Good afternoon, Director Kent, and welcome, and please proceed.
Sure. Jennifer Kent with the Department of Healthcare Services. I also wanted to just take an opportunity to introduce Adam Dorsey from Department of Finance. And so this is an odd world in which health people get to work with tax people. So to the extent that there are questions on the tax side, Adam can certainly field those questions. Just taking a step back, we have in this state had 3 managed care organization taxes over the years, the first starting in 2005, which was an act of Congress that was in place from 2005 to 2010 at 5.5% on the Medicaid plans only. That was phased out. And so in 2009, we instituted a gross premiums tax on Medicaid plans. Again, 2/3 vote. That was in place for about 3 years. And then we moved that tax to the state component of the sales tax, which is the MCO tax that we have in place today. Obviously, the amount of the money raised has increased over time. Medi-Cal has increased over time. These have been taxes that have been revenue-based taxes. And so right now, the current MCO tax that expires on June 30th of this year is approximately $1.1 billion to the Medi-Cal program through increased general fund that obviously helps support the overall program expenditures. And just from a note as well, Medi-Cal consumes between $18 and $19 billion in general fund each year. Our total budget is around $92 to $93 billion. So what happened to change the current tax, and why did we have to come up with a new proposal? The state Medicaid directors received a letter in August of 2014 from the federal government saying you can no longer tax Medi-Cal or Medicaid organizations, managed care organizations, solely on Medicaid lines of business. You have to change those and make them broad-based provider taxes, which are subject to certain federal rules. So that obviously for us and several other states meant that we had to go back to the drawing board and work with the health plan industry to construct a tax that was broad-based and met federal requirements. The first proposal that was released last year with the budget was certainly one iteration of the model. It was pretty resoundingly rejected by the health plan industry, and a lot of outside interests said this is simply not affordable. And so we have worked over the course of the last 14 months, listening very, very hard to both business as well as health plans on the impact to their purchasers, which is we have to do more to impact affordability. The first model had no other tax changes. It was simply a provider tax. Over the course of time, and I think, time has actually been helpful in this case in that we have had an iterative process that this model has moved along. We now have a proposal in front of you that we believe meets the affordability and sustainability goals that we set out with in the beginning of this discussion, which is we are very sensitive to the fact that there are commercial ramifications. And so we have tiered this tax and we have structured it in a way that also includes tax reform changes, both to the gross premiums tax as well as to the corporate tax, that we believe in very simple language represents a tax swap, in that we are zeroing out those two tax liabilities for plans and in turn instituting a managed care organization tax that raises approximately $1.3 billion net revenue each year. The last couple of items that I just want to highlight for you in this proposal is, again, listening to the plans. They had concerns about our previous proposals where the model was based on quarterly enrollment. That's extremely volatile, and obviously from a business perspective, very hard to plan for. And so in January, we proposed to make this what's called a static model, meaning we are locking in a certain base period of data in which the plans will be taxed based on their enrollment data for a certain amount of time that is already passed. And that is for the full 3 years of the tax. That is the numbers that we will be using, so there's not any volatility in the model itself. And then finally, our first iterative proposal had no sunset date. I think that we have, in talking with the plans and others, agreed that a 3-year sunset is certainly making sense from the standpoint that the market continues to change and evolve. Enrollment is obviously going to change, and I think we all want to come back in 3 years and assess how this has worked, both from a state financial standpoint as well as from a plan financial standpoint. So with that, I will stop and answer any questions.
Thank you. Are there any questions from any of the members? Yes, Senator Morlock.
Thank you, Mr. Chair, and thank you, Ms. Kent. I'm an accountant, so I want to ask a few accounting-type questions.
Oh, boy.
We are, maybe just to frame it all, we are working with federal laws, because we need to communicate this to our constituents, and we're saying we got to spend a dime to make a quarter, which is something my mother said, one of the parent tapes I heard all the time. So we're spending a dime to make a quarter. So we spend $1 billion, we get $2 billion back. How do we explain that awkward trade-off? Why doesn't the federal government just say, you've got a Medi-Cal system, it's working, it's been here for decades, we understand it, here's $1 billion?
So, it's a good question. Medicaid is a state-federal partnership, and obviously it is far more complicated from a financing standpoint, but the basic requirements for us as a state has always been that we have to put up 50% of the matching funds. And so what we have done over the years have evolved our financing structures to, in many ways, generate what we call non-federal share in order to alleviate pressure on the general fund. We have a hospital fee in place that obviously helps support some of the hospital rates in the state of California. We have a nursing home fee in place that helps support nursing homes. The managed care tax has been the third tax base proposal that has provided the non-federal share from the state perspective so that we could draw down federal funds. So this is, both consistent with what we've done in the past in terms of trying to make sure that the general fund is protected in times when it's extremely volatile. And so that is really what the conversation has been about, is not trying to fill the entire hole for the general fund, but obviously when the economy goes down, Medi-Cal goes up. We are counter-cyclical, and I think that we are in a fairly healthy period economically right now, but obviously, as you know, that comes and goes. And so what we're saying is the immediacy of needing to have this in place is that we are looking out 2 and 3 years down the road, and if there is a problem, we would really like to be able to have a stable funding source as opposed to watching the general fund disappear. And so it's a dollar in and it draws down federal dollars, and we're just trying to use a non-general fund dollar to help protect.
And so when I look at the little bit I've got on what the federal government requires, it says that all those paying in have to pay the same rate. So I've been here before. I served on the Cal Optima board for 4 years, so I had a county-operated health system experience, and so you pay a dime, you get back a quarter. That made sense there in a nonprofit setting, but you've got like 3 different rates, from $1 for one group and then $40 per member in another group. How does that get around the same rate?
Sure.
Provision?
Sure. So in its very simplest form, provider taxes from a federal CMS perspective have to be broad-based and uniform. You can apply for a waiver of those rules with the federal government as long as you meet certain statistical tests. And so this proposal would be seeking a waiver from the federal government for broad-based and uniform, meaning we do have different tiers and different levels of taxation. And so we have run a model that meets all those statistical tests. And so that is what we would be submitting to the federal government, is to say it's a fairly broad-based and uniform test in terms of, there's a lot more plans involved. We have limited the tax to certain populations. We can't tax Medicare, for example, so those members are not taxed. But all of those things go into a very complicated statistical test that the model meets, and that's why the numbers look a little different.
And then it also says no indirect guarantee, but we're looking at removing the gross premium taxpayer tax, and we're looking at modifying the corporate tax. And so I'm wondering, how does that get around the indirect concern?
Sure. So we call that, or hold harmless is kind of what that's in reference to, is you can't, in a provider tax, hold harmless certain tax-paying entities, meaning the federal government wants to see, we call them winners and losers, in terms of they want to make sure that you're not just moving money around and not having people actually pay something. We, through working with our legal counsel in DC that has worked with us on all of our provider tax, worked with a lot of other states, these tax policy changes, meaning the changes to the gross premiums tax and to the corporate tax, are not guaranteeing any particular plan is held harmless. And what we have and what we will be arguing to the federal government is these are just simply tax policy changes taken more broadly, in that we were going to impose a new tax, and in doing a new tax in California to work better for our state, we removed 2 tax burdens from plans. Now, some plans pay both taxes, some plans pay one, some plans don't. And so I think that's where we are very confident that we don't have a hold harmless situation, because not all plans are treated equally under the model, and it's certainly not our intent to hold plans harmless, but we were merely changing tax policy in California.
So then in paragraph 16, it says the following income is excluded. Mm-hmm. So that's sort of your offset, and I like that idea. If you're going to pay and you get an offset. But if I'm excluding certain types of income from a corporate return, I could be generating a net operating loss. Is that correct?
Okay, my lifeline.
Adam Dorsey Finance, that's right, and that gets back to the hold harmless issue, is that there may be entities that aren't able to benefit from the tax reform pieces of the proposal.
So then, is that net operating loss available for carryback and carry forward?
I wouldn't know. We'd have to get back to you on that.
Give me someone serious from the Department of Finance, please.
From Finance.
Good afternoon, Jay Chamberlain, Department of Finance. Just to answer your question on the net operating loss, while the income is excluded, and there could be a net operating loss in such a situation. However, any of the deductions associated with that income would also be excluded.
Okay, that helps, because I'm sitting here going, well, that's a bonus. For some of our for-profit corporations, I don't want to be bagged is what I'm digging for. I just don't want to wake up and say, oh, look at all the refunds that certain carriers got. Thank you. So we have a 3.9% tax on total revenue for the Medi-Cal MCOs. What does total revenue mean? Right, I'm not used to taxing the gross. I'm usually taxing the net.
So the sales component that is applied to the Medi-Cal plans today, it's on their actual Medicaid revenue. So we're applying the state sales tax rate to their total Medicaid revenue. So then we say the total revenue raised is off of that, off of their payments that they receive from us. We tax it. There's a gross amount that is raised by that tax. We have to pay the plans back through their rates. For the Medi-Cal plans today, and then the net amount is where we get to the $1.1 billion.
So you refer to it as a sales tax, so it goes to the State Board of Equalization, and it's not a corporate form that's filed?
Not exactly. So it's a tax on managed care, Medi-Cal managed care revenue that's based on the sales tax rate. And so it's actually 3.9% because that's the amount of the state sales tax that goes to the general fund. The current tax is collected by BOE, but it isn't the state sales tax.
But it's something equivalent with its own form going to the State Board as opposed to the franchise tax board.
That's right.
Okay, that helps. I think that those are my questions for now, Mr. Chair. If I could maybe ask questions later, would that be fine?
Sure. So let me just tell you who we have in order. I believe we have Senator Pan, Senator Leno, and I'm not sure if Senator Bell, or Senator Morrell was first, but it's one or the other, and then we have Senator Nielsen. So we're kind of going that order. Okay, so we'll start off with Senator Pan.
Thank you, Director Kent. Just a couple questions just to, in terms of on the health side, but maybe one financially is that, so because it's a federal match, the actual impact to the Medi-Cal program is twice as much as the general fund, correct? So we're talking how much money then for Medi-Cal?
Generally speaking, our federal match is 50-50.
Right.
So if we have to make a $1.1 billion reduction in Medi-Cal, it actually, from an outside payment standpoint, it's $2.2 billion that is removed from the program because you also lose the matching dollars that come with it.
Right. And I know that at least some of the initial financial projections on Medi-Cal expansion were to create 100,000 new jobs in California as we were expanding. Obviously, you can't, but someone asked about impact on businesses, but clearly this funding would actually, $2.2 billion probably pays not just for services, but for jobs, correct? Is that something you think that would have an impact on?
Right. I mean, I think that when you take a step back and think about Medi-Cal as an economic driver in the state of California, we spend $90 billion a year. And so that obviously pays for a lot of providers. It pays for their staff. It pays for services. It pays for pharmaceuticals. It pays for durable medical equipment. So that is a significant driver. And obviously, to the extent that we have grown by 5 million since the start of January of 2014, those people are being treated by providers, and those providers are getting payments. And so, yes, anything that reduces funding to the program then also has a doubling effect in terms of you're pulling the entire reimbursement out.
Correct.
So I think that's a fair statement.
Okay, thank you. Certainly as a Medi-Cal provider, as a physician who takes care of Medi-Cal patients, I know that when Medi-Cal rates get squeezed, not only, of course, our main concern is patients having difficulty access to care, but I also see the clinic then reducing the number of clerical staff, reducing support staff, et cetera. So those are jobs that are being lost, and obviously it does have an impact on service as well. And then finally, I know that prior to the ACA, we were talking, and even when Governor Schwarzenegger was here, was doing health reform, people talked about the fact that private insurers, people with private insurance essentially were spending about $1,000 more, probably about $1,000 worth of annual premiums were actually going to subsidize the care of people who are uninsured. And now that we've expanded, and again, with Medi-Cal expansion, I think would it not be unreasonable to conjecture that actually our ability to sustain our Medi-Cal program is going to be important actually in helping reduce the rates that hospitals and doctors and other providers may have to actually charge private insurance plans because they don't have to do as much of the cross subsidy. Certainly we have more to do on the payment rates, but at least having some more resources would be something that would actually help decrease pressure on private insurance, people who are, all of us who have private insurance plans, in terms of pressure on those health plans.
Right. I think that's an excellent point. And obviously, the cost shift in California has certainly changed since we implemented the ACA, and you have seen that in other states where they have not. But I think your point is well taken, that there is, there has been, and it has been mitigated some by the ACA implementation in California, that the cost shift is certainly less.
Okay, thank you. And I'm sure that after your testimony, we're expecting to see the supporters of this proposal, which I understand will include the health plans, but we'll wait till they come up and they can explain their own position. Thank you so very much.
Thank you. Senator Leno.
Thank you, Mr. Chair. And Director Kent, it goes without saying, hearty thanks for your focus, your dedication, your tenacity, your persistence in finding a way that we could meet the federal requirements and thresholds and at the same time create a new plan that would be equitable and that will save the state from being in a position of losing over $1 billion. I mean, that's no small accomplishment, and I know we have yet to take a vote, but you've really presented us with a quality product, and so I'm not alone here to say how appreciative we are. Clearly, there's some things to further clarify. The overall benefit to the state with the passage of this would be in the neighborhood of about $1.3 billion annually. And this is new and dedicated, new revenue source. The governor's proposed budget, which we'll be hearing in the coming weeks and months, allocates about $0.2 billion of that 1.3. So it leaves unallocated about 1.1 billion. The reason I dissect all this is that, as the chair mentioned in his opening comments, though this piece of legislation does not allocate that 1.1, so many of us here have expressed an interest in making sure that we can restore the damage that we've done to the delivery of services for those with developmental disabilities. In round numbers, it's approximately a $300 million a year price tag. I don't think anyone here could suggest we've got an extra $300 million out of our current general fund, and with prospects of a weakening economy, I don't want to be throwing shade here at all, but we know that the stock market is rocky these past few weeks. There are uncertainties around the world. This would create a new and potentially dedicated revenue source for something many of us, I know across the aisle as well, would like to see funded in the neighborhood of around $300 million a year. There's also the desire to restore most, if not all, of that 10% cut to those who provide medical services for Medi-Cal beneficiaries. That's in the neighborhood of around $250 million a year. You add it together, over $500 million out of our general fund, almost impossible to do, if not impossible. But out of a pool of 1.1 billion, maybe 50% of it. So this could provide us some great opportunity here. And I'm here to put myself on the record that should we accomplish this task in the next week or so, I would very much like to dedicate at least 50% of it to those two specific needs that we have not been able to address in recent years. Did you receive a letter from the Association of Health Plans? I think I got the name right. That's the formal name.